Symposium at ESC 2020 titled Towards a New Standard of Care in CAD and PAD, from Trial Results to Guidelines and Beyond. This is a disclaimer slide describing the scientific rigor of this symposium. I'm going to do a brief introduction and welcome you all, so thank you very much for joining us, and then move on quickly to the rest of the symposium. These are my disclosures for completeness. Now, the important discussion today is really about managing our patients, our patient populations that have coronary artery disease and PAD. That's our focus. The ESC guidelines recently changed the concept from stable ischemic heart disease to chronic coronary disease syndrome, so CCS. And you can see in this guideline document, the figure right from the guidelines, how nice that is described. So on the bottom line, we know there are a group of patients that really have a single stented procedure for stable angina and really have good long-term prognosis. In the middle bar is maybe your so-called standard ACS patient that is moving along, has subclinical disease, develops an ACS event, and has ongoing risk, which is maybe in an intermediate category. And then there are those high-risk patients, either because of other comorbid conditions or recurrent events, and really those are the ones at the highest exposure. On the PAD point of view, we've seen very similar data. If you look at a patient that has survived and had a revascularization event, a peripheral arterial revascularization event, they're at really significant ongoing risk over time of a cardiovascular event, shown here as MI and stroke, but also of recurrent limb events, limb revascularization and major amputations, showing the similarity between our CAD and PAD patient populations. It is the same disease in the end. And we're in an exciting time. There's been a lot of new data. This new data has given us new opportunities to treat these patients. The guidelines have changed to reflect this new data, and I think very applicable guidelines in that they allow us to really look at how to optimize care of these patients. And really what we want to talk about today is applying some of these guidelines to our patients and really developing that confidence in clinical implementation. We have an exciting agenda in front of us. My welcome and introduction is coming to a close. Professor Steffel will actually follow along next with protecting the patient that needs more, moving from stable CAD to the chronic coronary syndromes. I will come back and talk to you and give you a bit of an interventionalist perspective, talking about how can we protect patients long-term after PCI. Professor Bonacca will then talk about protecting the patient undergoing lower extremity revascularization for symptomatic PAD, really get into the Voyager results, which is new and exciting data. And then at the end, Professor Brodmann will actually come back to optimizing patients or protection for patients with symptomatic chronic PAD. As you can see, we have a scientifically packed and exciting agenda. We will take your questions through the chat messenger, so please enter your questions as you go, and we'll discuss those at the end of the session with a live question and answer session. I'd now like to pass the symposium over to Professor Steffel.
Thank you very much, Rob. Great pleasure, obviously, to be doing this with you, and of course, with everybody else who's joining us today. Please remember that you can key in your questions through the chat, and we'll tackle as many as possible at the very end. Now, it's my pleasure to talk about the patient who needs more. And as we're moving from CAD to CCS, chronic coronary syndrome, what does that imply? These are my disclosures. And I want to do this with the example of Mrs. C. So this is a 63-year-old woman, dyslipidemic, diabetes, hypertension. She's had a non-ST elevation MI 3 years ago with stenting of a high-degree lesion in the right coronary artery. Currently, she's completely asymptomatic. Her echo shows normal function without relevant valvular disease. And she is on aspirin, a statin, beta blocker, ACE inhibitor, metformin, and on an SGLT2 inhibitor. So she would appear like your typical stable CAD patient. But when we take a look at the data, in fact, these patients are not all that stable. And that's exactly where everything starts, because we have that perception that these patients don't need more protection. But if we compare a healthy patient, if you can see here on the right-hand side, a healthy 60-year-old with somebody with a history of cardiovascular disease, myocardial infarction, or stroke, you can see that these patients have a relevantly reduced life expectancy and a relevantly increased risk of events. And this was appreciated, or this is appreciated also in the current guidelines, the current chronic coronary syndromes guidelines from last year's ESC and published in the European Heart Journal, where it is stated that a second antithrombotic drug, in addition to aspirin, should be considered in patients at high risk of ischemic events, obviously without a high bleeding risk. And for these patients, it's even a class 2A recommendation with a level of evidence of 8. It's still a 2B recommendation in patients at moderately increased risk. Which are those factors who would give you a higher or moderate risk? That's a little bit debated. The combination of diffuse multivessel CAD plus any of the risk factors you can see here in yellow, that would put your patient at high risk according to these guidelines. Whereas patients who only, in quote unquote, have one of those factors would be at moderately increased ischemic risk. However, if you take a look at this, for example, in the ESC score, many of those patients would actually also be qualifying as high-risk patients, say, for example, a patient with diabetes, peripheral artery disease, and so on and so forth. So some may argue that many of those factors actually would put patients in a high-risk category as well. What can we do? Well, in terms of antithrombotic drugs, there's basically two options. Number one, we could treat these patients with a very low dose rivaroxaban, 2 × 5 milligrams BID, or we could go for prolonged dual antiplatelet therapy. And the best data here are, in fact, for ticagrelor from the Pegasus trial. However, when we take a look at the Pegasus trial in a little bit more detail, these were patients only after acute coronary syndromes, of course, you can see that there was a benefit of adding 60 milligrams ticagrelor BID to patients when they were randomized 30 days to even up to 1 year after their event. However, afterwards, there was no more benefit. And in fact, this goes along